Good afternoon and welcome to the HL7 Da Vinci Community Roundtable. Today's session is Real World Successes, HL7 Da Vinci Project, Community Champions, Payer-to-Payer Data Exchange, and End-to-End Prior Authorization. My name is Alex Goss, and it is my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. This month's webinar showcases the progress and impact of the Da Vinci community. We'll first recognize the 2023 class of HL7 Da Vinci Project Community Champions, highlighting the impact of individuals as recognized by their peers in advancing value-based care standards in support of patient care and related processes. It's great to have Da Vinci's new steering committee chair, Anna Taylor, announce the champion awardees. We will then showcase two implementer efforts. First up is Availity and Humana, presenting a current snapshot of their efforts to advance payer data exchange capabilities, providing a learning opportunity for all of us of the challenges and benefits related to using the Payer Data Exchange, or PDex, implementation guide for payer-to-payer data sharing. Our second implementer presentation is from Athena Health, Availity and Humana. They will discuss an end-to-end prior authorization collaboration. This presentation discusses the goals of their collaboration, as well as the specifics regarding implementation, how the organizations approach technical, data, and standards-based challenges, reviews the critical lessons learned from the initiative, and provides key benchmarks and metrics of post-go-live success. These two implementation journeys will certainly extend implementer thinking around complying with payer-to-payer exchange and prior authorization support related provisions in CMS's 0057 final rule. Our presenters include Mark Fleming, Senior Director of Product Availity, Justin Howe, Senior Manager Product Availity, Humana, Amy Mattingly, Director Interoperability, Product Management at Humana, Jillian McCabe, Director of Product Authorization Management at Athena Health, Gurbinder Singh, Principal Product Manager at Humana, Anna Taylor, HL7 Da Vinci Project Steering Committee and Associate Vice President, Value-Based Care and Population Health Management from Multi-Care Connected Care. We'll have time for questions after each presentation, implementation story presentation, and I encourage you to use the Zoom platform throughout today's events. We'll post the recording of today's webinar and slides on Da Vinci's video presentation page on Confluence. Da Vinci's communication lead, Leslie Amoros, will be posting links in the chat box to assist in locating that page and other resources you may find of interest. Please be sure to use the question feature to submit questions, as we've limited the chat features for us to push key details to you and for you to be able to download that chat box so you can save those links. We've also muted lines to aid recording quality. Finally, we sincerely appreciate your survey feedback solicited at the conclusion of the webinar. In regards to upcoming programming, our next session is June 26th. Please note that we will be taking a hiatus in July. As to upcoming events, I'd like to showcase a couple of those for you today. AHIP 2024 conference will be held June 11th through 13th in Las Vegas. And there's a WEDI Summer Forum, August 6th and 7th, being held in Chicago that will also be hybrid. In regards to HL7 events, we have the 2024 HL7 Fire Dev Days right around the corner in Minneapolis, June 10th through the 13th. And we have the CMS and HL7 Connect-a-thon, a virtual, free, excellent event to attend July 16th through the 18th, and registration is now open. Without further ado, I would like to invite Anna Taylor and our champions to come on screen. Take it away, Anna.
Thank you so much, Alex. You're so good at that. And welcome to my champions who are here. I was a champion once upon a time, and I'm really thrilled to be taking on the role of chair of steering committee and honored to be able to share the awardees today. These are people who represent all the collaboration and work and time and space and talent that it takes to transform healthcare. I think one of my favorite parts of my day is when I get to be in this community, and these champions are representatives for which grow, nurture, and enhance our culture that we have created here to be able to transform the way we interoperate in healthcare, which is really exciting because the time is now to be able to do that. We have all the stars aligned. So on behalf of HL7 Da Vinci Project Steering Committee and its Da Vinci members, I'm pleased to recognize the 2023 Da Vinci Community Champions. Please join me in congratulating them. We do have emojis down below. I'm not sure if you guys have those available to you. So I encourage you to use those if they're down there, and to also put anything in the chat that you would want to say thank you to those people. So our first champion is MultiCare's Karen Ashton. And Karen Ashton is the Director of Population Health Digital Solutions. She's also been my colleague and my friend, and I'm super excited for her to be honoring her today. I have the pleasure of working with her throughout my entire career, which has been awesome. Karen has worked on the implementation of MultiCare's fire services on Azure. So MultiCare has a fire services, a developer portal, an API for which we can interoperate with our payer-provider relationship. And Karen was instrumental in making that happen. She was also the first one to say yes to the crazy idea of making this happen. So I'm going to say congratulations to Karen and all that she does to contribute to not only MultiCare, but this Da Vinci community and healthcare at large. So congratulations, Karen.
Thank you. I'm very grateful to have the opportunity to be part of this innovative and collaborative community, and I very much look forward to our continued progress.
Karen, you deserve it. You'll have to hold your trophy up and shake it, as are every single other person on the list. We'll need to do that. And the next person is Hans Buitendijk, and Hans isn't able to join us today, but we wanted to say our thank you. Hans of Oracle Health has been with Da Vinci since day one and has served on steering committee as well as finance and planning committee. I've had the pleasure of working alongside Hans, and I have learned so much from everything that he has contributed to the success of this community and this project. Hans has been a role model. This is a direct quote from his nomination. Hans has been a role model for how health IT leaders and professionals that operate in the vendor space give back to the standards community in a volunteer role, not only with Da Vinci, but with many other industry organizations. In his absence, Hans wanted us to share that he really appreciates being given the award, and I can hear that in his words. I want to thank him for all his contributions and congratulate Hans for his award this year. So thank you to Hans. All right. Our next Da Vinci champion, of which I've also had the pleasure to work very closely alongside, is Daniel Kaywood. And he is from MCG Health. Daniel has been one of the most active promoters, and I will say this, I've been on stage with Dan for the HL7 Da Vinci's project Fire Standards and Implementation Guide. His effort in 2023 helped evangelize payer, provider, and government stakeholders as they contemplated strategies to meet the requirements of the federal rules. So, and Dan, I just want to say something personally, which is you are really good at debating things. And I think that's super important, of which this community brings, is a space to debate what the right thing is going to be for the industry, for our patients, for our enterprise. So I really appreciate everything you contribute to in this community, and congratulations.
Thanks, Anna. I might need to get you to write down that you appreciate my ability to debate and send that to my boss. But yeah, it's great to receive the award. I'm very grateful for it, and doing a lot of important. This group is doing a lot of important work, so very happy to be a part of it. Thanks.
Awesome. Thanks, Dan. All right, our next champion is Naomi Meow. Like the cat, she says. She likes to tell me that. Thank you, Naomi. She's the business operations manager for Athena Health. And as her nomination notes, let's see. Okay, I'm on the wrong page. Of course, I had the pleasure of working with Naomi and can attest that she is a champion of Firebase interoperability, which she is. She worked tirelessly on the post-remittance use case in FireIG, Da Vinci's newest use case, with the goal of improving rev cycle in healthcare, which I can say, Naomi, is very important right now. So we really, really appreciate your hard work and dedication to this, and your super, super smart, sharp pieces that you contribute to this community and to that work. So we really appreciate everything that you've done and contributed to Da Vinci. Congratulations.
Thank you so much. I'm so honored, and I really look forward to more collaboration and projects and process in the future.
Congratulations. Okay, our next champion is Linda Michelson, who I have called many times to phone a friend and say, Linda, tell me how this goes again. I think she is the most resourceful person I have ever met, especially under that quality umbrella. You know every detail, every unturned rock that I can't think of. You know, you're 100% a partner in all of this, and I am very, very, very honored to deliver this today to you, Linda. You're extraordinary and most deserving of this recognition. And you were nominated for leading multiple Da Vinci education sessions. So not only does she participate in building things, but she's out there educating others about how we can use these implementation guides and how we can move things forward. So I really appreciate your ability to be in the weeds and think strategically. I think that's something that's very rare, and we're very lucky to have you in this community. So congratulations, Linda.
Thank you. I totally agree with everything everybody said. It's about the community. It's about education, helping people understand. We don't compete, we rise all boats, right? And the one thing that struck me the most from last week's working group meeting is we had a parent come who had two very critically ill with multiple issue children. He came to the working group meeting, to the Connect-a-thon and to the working group to try to get work done in the area, the focus on patients. And one of the things he said, which I feel is true of this entire group, is you people have more IQ in this work area than I think, the rest of the population combined. And if you cannot make this happen to help, our patients, our children, no one can. So he charged us with that responsibility, and that is always my goal. It's about making it work across the community, establish fairness, and that everybody participates, and that we educate to bring the people along that are newer. So I thank you again very much for this award, and I will attempt to keep living up to it over the next few years.
Thank you so much, Linda, for those words. I think that's why we're all here. Leave the world a little bit better than we found it, hopefully. The next person that I have the honor of introducing is Alex Muggy, excuse me, Alex, the Chief Health Informatics Officer and Director of Health Informatics and Interoperability Group for CMS. And we are super honored to have you here today and to present you as a champion. Your nomination notes, Alex is a key government partner with Da Vinci. Alex has been a champion in partnering government and private sector to advance interoperability through industry standards. I personally can attest that she always makes herself available to our community to lend a listening ear, to connect us to the right people. We were having trouble with some of the BCDA work, and Alex was right there beside me trying to figure out how we can all work on this in community. And I really just don't think we'd be as far as we are today without her. So I'm super honored to present this award to Alex, and very thankful for your partnership with Da Vinci and with our community. And as Linda said, all votes rise together, and you certainly bring us to another level. So congratulations.
Thank you, Anna, and thanks everyone. I'm honored to receive this award. You guys are all wonderful to work with, and I think we have made great strides together, so appreciate the recognition. Thank you.
And then our next champion, Shrikant Puram, our final champion, is from Metal Solutions, who we're excited. We've been working with Metal at Multicare. He has provided many contributions. As his nomination notes, he has completed many example fire questionnaires for the use by Medicare fee-for-service providers and their EHR vendors. These include elaborate skip logic required by the complexity of Medicare fee-for-service, local coverage determinations, and local coverage articles, and CQL for adaptive forms, which really makes me feel like we're super smart when you say all those things string together, which you are. So we're super thankful for having you here, Sheree, and everything that you contribute to the community. We need all the details we can to help figure out what the best solution is, and we need all the lenses of the world to look at that. So we really, really, really are appreciative of your time and talent and everything you bring. You are duly impressed, or I am duly impressed with these artifacts, which have been of great help. So congratulations to everything that you've brought to this community, and I'm so honored to be able to give you this award.
Yeah, thank you, Anna. I'm deeply honored to be named for this recognition. Together, I'm pretty confident that we are making a meaningful impact on healthcare interoperability. Thanks a lot.
Well, thank you so much. And thanks to all the champions whose efforts continue to inspire and transform healthcare. I wanted to take a moment before we moved on to the implementer section of this to recognize two people who have contributed so much to this community. And that is Susan Belisle and Dave Degani, who will be enjoying their retirement this summer. So make sure you reach out to them and give them a high five over whatever, LinkedIn, Instagram, however you're connected to them, because I know I wouldn't be here today in the position I'm in if it weren't for a plate of nachos that I shared with Dave one day. He's like, you want to do this Da Vinci thing? And he convinced me to be here. So super grateful for both of their contributions to this work. They worked tirelessly, both Susan and David, to make all of this happen that we've created in this community. And I'm really, really hopeful for the future and what the future brings, because we're living their legacies that they've left for us to continue this work. I think the culture will sustain itself. As Linda said, it's really fun to be with your people who you can talk about these highly complex problems with and come to this solution that is an actual standard. So congratulations to all of the champions today. And thank you to both Susan and Dave for their commitment to making a difference in the world. We all hope that we can do the same. So thank you guys very, very much for this honor of presenting the awards. Congratulations to the champions. And I look forward to hearing the implementer stories coming up.
Thank you so very much, and congratulations to all the champions. It's really, it's great to work with such amazing people. And speaking of amazing people, I'm going to invite our next presenters on, GB and Justin. So I got one of you. GB, you want to come on screen as well? There you go.
Hi,
All right.
everyone. Can you hear me?
Yes, sounds great. Justin, you want to do an audio check?
Absolutely. Hello, everybody.
Hey, let's kick it off. Take it away.
All right, thanks everyone. Thanks, Alex. Let me share some of the progress Humana and Availity team is making on peer-to-peer interoperability rule. We, in partnership with Availity, if you don't mind, Alex, going to the next slide, please. All right, thank you. As we were anticipating the CMS rule coming on board, we did not know the anticipated implementation timelines. And we wanted to be proactive in the industry, as Humana has always taken a leadership role to develop interoperability solutions. We started a partnership with Availity to look into what are the possible solutions, what we can develop. Some of the challenges what we identified in the beginning is the sheer number of connections, right? The last time I checked one of the websites, there were more than 800 registered health plans in America, right? There are health plans in California County. There are health plans which are specific to one Florida village, county, the villages, right? And the challenge is, how do you keep a directory of all these health plans together? How do we establish connectivity? How can we build a solution which is also easy to scale? And our approach is just not to develop a connectivity for the sake of connectivity. We want to look into the opportunities of using this information during the onboarding process and leveraging this data to the benefit of our new members. So as we were trying to figure these things out, Availity reached out to us. We started this, we signed up for this cohort where there are 3 other members, and with goal of developing a industry solution based on industry standards published by Da Vinci, or leverage some of the infrastructure which is already getting implemented rather than reinventing the wheel. So from that point of view, we are working on a solution with Availity to develop peer-to-peer compliance, to meet compliance for peer-to-peer API. Alex, if you don't mind going to the next slide. Justin, feel free to chime in.
Absolutely, GB. And it might be good to kind of point out a little bit of a look back here, because what GB was describing as our sort of partnership and our relationship has grown, preceded the final rule, which I think was one of those key elements that we debated and discussed and determined, even in advance of a final rule, don't we think we're still going to have a lot of work to do to go ahead and build some of these networks, establish some of these FHIR resources, and basically be able to exchange data in a way that's going to look pretty competent as we approach what is now, the 2027 mandate. But spending the last 6 or 8 months working together in this particular cohort or grouping of about 3 or 4 payers and Availity in the center is really where we wanted to set out and try to determine, what does an appropriate solution look like for that, knowing full well that, Availity serving as a router, sort of processing the requests and validating the member matching, dealing with a little bit of the FHIR tech spec in between, how can we best, offer the ability, like GB said, to go ahead and map out the different endpoints that are available and go ahead and register for some of those and handle a lot of that testing that happens early enough on, such that, we're moving ahead and really kind of figuring out what's in the guide that, is pretty explicit, and what are some things that we need to really discuss and debate. I think, having Humana there in the picture and then Availity in the center with other payers on each side, we worked through a few of these different challenges. And I know this is a little bit of a technical diagram, but when it comes down to FHIR and you start talking about synchronous processing and asynchronous processing, there's a little bit of debate and discussion around, what's the best way to handle that. And I think as we go forward and we start taking a look at, the next slide, where our approach is really kind of honed in on, how can we take what we're learning, iterate against that. Alex, if you wouldn't mind advancing us a little bit here.
Hey, Justin, can I chime in for one of those things? So just to, even though the final implementation date is in 2027, right? That seems really, really far away, right? In our world, right? Because we are always thinking of next month, what's going to be in the next release or next 6 months, right? But I would say one of the learnings has been there are so many gaps. What we have found out. I know you will be touching upon some of the gaps we have found out in implementation guides, how we are making those updates. But from payers' perspective, right? what we trying to do is trying to bring different business stakeholders within our organization to the table, right? And we are trying to give them enough time to develop processes to leverage this information. So this is just not a checkbox item. Hey, yes, we met this compliance, but how do we, in addition to that, how do we make the business use case out of it, right? So we've been talking to various business stakeholders like on enrollment and onboarding team, member experience teams, and things like that to integrate this capability or this information in various processes. Sorry, Justin, I didn't mean to. Yeah,
No,
but I thought
that's totally
business
appropriate. I
context
think
was.
that's
Yeah.
definitely one of the powers of Da Vinci and bringing the groups together, as well as understanding that you've got technology challenges, you've got business process challenges. We've got member outreach aspects that we're trying to account for. I won't call out the gaps in the guides, but there's definitely areas in there that as we started to figure out the best way to achieve success quickly, how could a group of payers sit down and work through some of those challenges, whether it's PDex, version 1 or version 2. I think a lot of that healthy dialogue emerged over the last 6 to 8 months to get us to a place where we feel really comfortable and confident in what we're delivering. But more to the approach, I guess, the incremental approach is what we're really trying to figure out through, a small group that's, working through common, issues and challenges that we see building out some of these first, MVPs, the minimally viable product that we'll take to market, collaborating and participating in the PDex work stream, having a presence here with Da Vinci and working with the smart people here. It's a little tough following that champions group to understand, some of the great work that's happening there. But then as we establish our own cohort within Da Vinci with these members, we're building that network effect. We didn't think we'd have it right off the bat. As a matter of fact, GB and I had some great conversations early on in terms of how to scale our initial offering that wasn't too ambitious and would take it too long to get to market versus proving the viability of the existing solution and then iterating against it, which is all that fancy word around, let's make sure that we're getting the basics right before we go ahead and try to get, really fancy with everything. In doing so, and in recruiting more payers to join us and sort of demonstrate either through best practices, some of the documentation that we have, we established that routing hub that you'd connect to the hub once, and then you'd be able to gain access through the endpoint directory to determine everybody who's out there actually doing these FHIR transactions today. And then as we can either coach them along or onboard them through the Availity solution, they'd gain access to Humana and some of our other cohort members. But we're able to, get that reach. Also, and this is pretty important, is instead of managing a series of point-to-point networks out there, hopefully we're minimizing that overall maintenance. For those of you that have to do, platform upgrades or, enterprise overhauls, the maintenance of keeping those endpoints updated and maintained is really going to be a task that Availity is taking on as part of this. And the idea here, again, with the approach, that endpoint directory is hopefully going to help people understand, how we're scaling the offering, not just as we approach the deadline, but, throughout 2024 into 2025 and beyond, and then hopefully build that trusted network that we end up having, a good solution offering that allows people to plug in once and then gain access to get data on their new member as consented, and then reaching back to some of these members, or sorry, some of these payers that they were previously associated with, and really facilitating what's going to be, I think, a better member experience. I know GB is going to talk about this in a second and kind of what that looks like, but the idea here, again, just to reiterate, bring that group of payers together, have somebody like Availity helping facilitate that, ask the tough questions, and then iterate against some of the things that we're seeing.
Thanks, Justin. So in terms of, yes, we know the connectivity would be there. We will be able to get the history, but how do we leverage that information? Right now, probably all of us working for payer organizations, we go through this challenge where we do not know anything about new member coming to our organizations on day one. It takes us just 3 months, 6 months, or 9 months. Or if somebody needs to file a claim, before we start to know about this member, we need to create their profile. We need to run some analytics in terms of figuring out what these members' needs are. But with these guidelines, what we are planning to do, or what our intention is, as we get this history from a previous payer, how can we serve this member better? Can we enroll them in fall prevention program based on their history, right? What we might have got from the previous health plan. Right now, we do not have any way to figure that out. Can we highlight some specialists this member might be seeing, which are out of network based on whatever plans they have signed up? And same goes for other quality and risk adjustment measures, right? How can we check on them and serve these members better as they join this new organization? So this is in very early stages. We are working on various concepts, but our intention is, just like in financial industry, a member is moving from one credit card to another credit card, and they are carrying their credit history. So this could be a payer history which they should be able to access, and we should be able to leverage to serve them better.
So where does that leave us? I mean, we'll get to some questions in just a minute here, but GB and I delivered this back at HIMSS initially. We thought a little bit of, where is the Venn diagram going to emerge around how you bring payers together with other industry stakeholders and the likes to benefit overall. And I think, by and large, even with the final, rule pushing the data out a little bit, the success we're finding is getting started early. We've actually already been through a number of different testing workshops and connect-a-thons, sort of sharing what we're learning and then taking in new perspectives. Humana has been instrumental in a lot of this work. So I have to say thanks, GB, and to your team. But at the same time, we're also sharing some of that learning back to the different groups, helping them either add to the implementation guides or at least take things under a different lens as we start to present some of these new challenges, whether it's about member matching or authentication or, some of the stickier details when you get down in the weeds around some of these things. But by and large, as we bring these groups together and we kind of commit ourselves to these weekly meetings and these, testing events and things, we're hoping to accelerate overall that development to get into this end-to-end what if scenario. And we could basically hopefully be in a place where we're delivering these production transactions well in advance of any of the mandate things, just for some of the same reasons that GB just pointed out, and the benefit that can be derived by getting some of that member history earlier on versus, maybe they don't even have an encounter in the year that you first get them. So I think that's going to be really important. And I think the collaboration that we're seeing is really paying benefits here is starting early and then getting engaged and involved. GB, did I leave anything out?
No, Justin, I think so you covered it. And just wanted to say, if there are any questions, right, please feel free to reach out to Justin or me. Happy to collaborate. I think so as part of this industry collaboration, once we do these collaborations and build solutions together, we are strong, right? We can give feedback to various organizations, stakeholders, on what needs to be done and where the industry needs to go. Thank you.
Absolutely. Well said.
Yeah. It's great to hear about your collaborations and leveraging the implementation guide for payer data exchange. I noted that you've brought a cohort of participants together, but I'm a little unclear about when the production goal might be on your horizon. Sounds like you're working through it as a kind of a multi-party engagement, but I'm not clear, like, when do you, because there's part of turning on the technology, and then there's that operational workflow that you talked about. So is there a goal that you're looking for having it available in production?
That's a perfect question, Alex, and I couldn't have teed you up better. We're really at our second to last milestone with our end-to-end testing right now, where payers are starting to get the resource data back and forth between each other to really understand and interpret, how is it working as they receive it and then process it. We expect to complete that over the next couple of months. At that point in time, our production build will be deployed to the point where we've got the ability to announce GA. But we're also recruiting in new payers. So as we talk about what's going to happen in the next couple months, we're also doing more outreach and engagement. I wanted to highlight, as GB was pointing out there, early on in our cohort, one of the first key points that was hammered into us was adoption's really the key. There are certain mandates that have been enforced, but they're not really well adopted. So, the best is when we've got more and more folks participating where the data is being shared in the way that we expect it to. And I think once we finish end-to-end testing, later on this summer, we're going to be announcing GA.
That's awesome. One of the things I think is really important for industry to realize is that an implementation guide gives you a basic recipe for how to get your infrastructure functioning and interoperable. That is only one piece of a complex recipe, which is to actually integrate the data that's going to flow through that infrastructure into your operational capacities and capabilities. And I really appreciated that you called out that the set of conversations that you've been having really are thinking about not only about the pipes and the core data sharing, but there's the aspect of what are you going to do with that as you actually get that data and move into that production environment. I noted that I have a question that I want to weave into this conversation. Is the assumption that payer A and payer B are in parallel, or one payer after another, or both? That is, for a patient who has dual coverage or a patient who changes plans.
So that's a little bit of a technical question, and I love it personally. Like, these are some of the things that the group has been wrestling with a little bit. And it is a little bit A to B, meaning new payer to old payer, to reach back and request that history. However, that's one of the areas that we're now starting to figure out with dual coverages, how to best manage some of those things. And the way that the router mentality works, with a new payer requesting through, say, an Availity, to then send those requests out to previous members, payers. It's always new payer and old payer, but then the member is in the center here type thing. The idea is that, the request would be processed through from, say, Humana back out to, another, member payer of our connectivity hub, and then they would receive that data back. But it is possible that two plans before that member was a participant in a totally third payer in the mix, and that's something else that you would then be able to route through the Availity payer-to-payer solution. And we expect, we're kind of wrestling through what that best practice looks like, so that everybody can kind of stay, align in the best way to handle some of those resources as they go through.
Sounds like an opportunity for me to come back and share lessons learned from that experience.
Look forward to it.
Well, Justin and GB, thanks so very much. We do have a lot still queued up for our prior authorization support end-to-end showcasing. So thank you, gentlemen, for coming and presenting your story in payer-to-payer exchange. Look forward to your continued success with leveraging the payer exchange as a strategic asset, not just a compliance opportunity, which I think is a really important endeavor. Thank you. Going to, at this point, invite on our next set of presenters, Amy Mattingly, Jillian McCabe, and Mark Fleming. All right, let's go ahead and turn it over to you and advance your slides as we go.
Great. Thanks, Alex. And thanks everyone for coming today. So as Alex mentioned, today we're going to talk about our real-life implementation of the HL7 Da Vinci Burden Reduction Implementation Guide. So during this presentation, we're going to review really a background of the issues at hand and our goals for the work that we did. We'll also review a little bit about what we did within this work, but spend the majority of the time talking about any outcomes that we've experienced since going live with this functionality, and lessons learned that we've shared with others and we've provided feedback on. So with that said, we're going to start a little bit, and Alex, next slide, sorry, forgot I'm not controlling. So we're going to start first about just the background. So for anyone in the healthcare industry, you can testify that the prior authorization process is one of the most frustrating parts in healthcare. I hear it all the time being on the health plan side, but in fact, 89% of providers report that prior authorization requirements have directly impacted their staffing models, requiring either additional or a redistribution of their staff. And while prior authorization is frustrating, most people understand why it's absolutely critical for the industry. And at the core of that, there are many reasons, but really at the core is ensuring that the member or the health plan member and the provider patient is safe, and the safety is a top concern. So, but due to the complexity of the prior authorization processes, we know that there is also a negative experience for the members, as studies have shown that about 94% of providers have reported that the prior auth requirements have caused delays in actual patient care. So this is not ideal. So we really want to look at how we can continue to improve this complicated process so it can be easier and more efficient. So as we go to our next slide, we really look at the goals that we set out to achieve. So knowing that this is a significant issue, Athena and Humana partnered to identify a way to improve these processes. Since Availity serves as the clearinghouse for Humana, we brought Availity into the conversations as well to help us with the solution. All three parties were part of the HL7 Da Vinci work group, so we decided to try to tackle this work using the HL7 Da Vinci Burden Reduction Implementation Guides. Our goals with this work were really to improve the transparency into the prior authorization process for providers, reduce the administrative burden for both providers and the health plans, leverage available clinical content at point in time, and increase opportunities for automation along the way. So ultimately, all of these goals at the end of the day result in better member or patient experience. So what did we do with this work? Next slide. Most people here are probably familiar with the diagram that's on the left side in some fashion, if you're familiar with the burden reduction implementation work. But to the right, we've really broken down how we implemented each step of the process. I know it's a little hard to see, so I'll walk through this a little bit clearer. So as with the implementation guide, we really developed this work in 3 phases. In the first step, was the coverage requirement discovery component of this work, where a direct connection was established between Athena and Humana, which a provider could real-time determine whether or not an authorization is required for the services at hand. This response could include a real-time response of auth not required, auth required, or other validation responses that might share additional feedback that the provider needs to take action on. If the authorization was required, we may also provide at this time responses back that include both the authorizations required and additional clinical information is needed or questionnaires completed. This takes us to the second part of the implementation around documentation templates and coverage rules. At this point, if the authorization is required, a URL would be shared back with the provider directly within their workflow. Upon clicking of that URL, the provider would be able to launch a Smart on Fire app where they could complete responses to clinical questionnaires, which then will be sent directly back to Humana real time, and that data would then be used within the authorization process when the authorization was requested or was finally submitted. If a questionnaire is not needed, at this time we would potentially also request clinical documentation. At that time, a provider would be able to collect the information needed within their system and have it ready to be submitted along with the authorization. This takes us to our third part and where we see the involvement with Availity. In step 3, which is the actual prior auth support, this is done, Athena Health bundles the authorization request along with the clinical documentation identified into a FHIR bundle, which is sent to Availity. Availity then translates that information from the FHIR bundle into X12 standards, in which sends it on to Humana. Humana will take that authorization using our normal standard processes and run it through our rules at the Humana side, our logic. We'll take in that authorization data and we'll also apply the responses to that clinical questionnaire that was previously answered. Upon real time, that authorization is created and a response is generated back through Availity and going back into the provider's workflow within Athena Health, and that response will include the auth number and the auth status. If the authorization at that point in time cannot be automatically approved based on the information we received, we will trigger at a later point, once the authorization is decisioned, a real-time response back, which eliminates the provider's need for continuous inquiries or calling for updates to the authorization. I do want to call out one step of this that might have a few people questioning. I get the question often, which is the translation component of this work that we implemented with Availity. So if we take, at the time that this work was first kicked off, we didn't know if the FHIR work would be acceptable for all submissions long term. This started many years ago, so we were being safe and ensuring that we continue to follow the X12 standards that were currently existing, which is where this workflow came from. So while I'd absolutely would love to identify and implement a full-blown FHIR burden or a FHIR bundle directly from Athena to Humana, Availity was able to quickly close that gap for us. So as we go to the next slide, we can see what the actual provider experience looks like. These are a few of the screenshots that the provider would see directly within their Athena Health workflow. So the top slide shows what the provider would see if upon submission of the CRD, an authorization is not required. At that point, the provider could see real-time authorization not needed, and they could continue on with services. On the bottom, it shows the authorization has been submitted and is in progress. upon reception of the updated status, this would then translate to approved, which the provider could then know to go on and book the services or move forward. So as we look at the timeline and the progress that we made to date, and next slide, you can see that, again, this work really was, while we have 2022 as listed as the first kickoff date, this work actually started early 2021 as we started coming together and identifying the approach. In 2022, the summer of 2022, we were able to implement that first phase. As I mentioned, we did this in 3 phases. That first phase was able to be implemented in summer 2022, where we were able to turn the CRD capability or to determine whether or not an auth is required live into production and usage for the providers. In spring of 2023, we implemented the full end-to-end integration, which included all 3 use cases for a small beta population. Once we confirmed that that integration was working as expected, in summer of 2023, we started rolling out that capability to more providers and continued to expand throughout 2023. At this point, we are live in production and continuing to see usage of the work from an end-to-end standpoint. And we're, along the same lines, looking for areas of opportunity which we may have missed in the beginning. So at this point, I'll turn it over to Jillian to talk a little more around the work that we actually are experiencing and the outcomes they're seeing.
Awesome. Thank you, Amy. So as Amy mentioned, I'm going to talk to you a little bit about the outcomes that we were focused on evaluating to understand the success of the integration. So 3 areas were where we primarily focused on to evaluate the outcomes of the integration. The first one is on burden reduction. So one of the objectives here is to really make sure that we are deploying a solution that does generate time savings for the practice staff by integrating this real-time connectivity between the EHR and the payer to be able to generate those outcomes really seamlessly. So we wanted to better understand, are we actually making a meaningful difference in reducing the amount of time that it will take staff to process authorizations. The second area is looking at touchless resolution. So how often are we able to provide an outcome to the practice, really minimizing the effort that they need to engage with in order to provide additional information or insights to the payer in order to process that integration. And then the last piece is on fast resolution. So are we ensuring that all required data elements are gathered upfront? Getting those in ahead of time means that the package of information that the payer will ultimately receive is thorough and complete, which ultimately tightens up the overall resolution timeline because the payer doesn't need to do any back and forth with the practice, which can often occur when processing these types of authorizations manually. And humans in a process just lead inevitably to flaws along the way. So we want to look at sort of how the automation of the overall solution is adding some value in the timeliness. So if we go to the next slide, we'll dig into the first area on burden reduction. So one of our goals here is to evaluate how we performed against denials, really thinking about that upfront gathering of documentation, and did that actually lead to more positive outcomes overall when we look at the volume flowing through the integration. The other dimension is to look at the time saved. So, how much burden are we actually reducing for those practices that are engaged with the integration? So when we look first on kind of reducing denials, so we were really pleased to see that there were 0 authorizations denied due to lack of documentation. So those of you that are really close to authorization processes know that, as I mentioned, you put humans in the process, and that really can lead to some unfortunate outcomes. Documentation might be present in the EHR, but perhaps it's just missed in the submission and it doesn't make its way over to the payer, resulting in, unfortunately, a denial just due to the lack of documentation present. So again, really pleased to see 0 authorizations denied due to lack of documentation. Additionally, on the time saved side, there were an average of just over 17,000 orders with a no auth required outcome. And when you look at about 15 minutes per order to validate that no authorization required status, that averages out to just over 4,000 hours saved per month across all the clients using the solution. So really generates substantial time savings by providing those real-time notifications, particularly in the case of when there's no authorization required, And that really eliminates all the staff work that they would need to do, either calling or using a portal to verify those requirements otherwise. So if we go to the next slide. So thinking about touchless resolution, so kind of related to what I just mentioned, that no authorization requirement rate for, and I should have mentioned as the lead into the outcome section, these metrics are all across Q4 2023. So this is October, November, December of just this past year, for which we have an average of 54% of a no auth required rate. So really just over half were able to kind of quickly come back with that no authorization response, which really unblocks practices to proceed immediately with patient care, which generates positive outcomes for the patient and the provider. Additionally, we were really pleased to see a 70% auto approval rate. So for those orders that are flowing through the integration, 70% on average are able to receive an auto approval. So, near real time, Humana responds back via the integration that, everything is approved. Again, really driven by that upfront gathering of necessary data and clinical documentation. So super excited to generate those outcomes with the integration. We'll go to the next slide. So the third area, thinking about fast resolution. So some of the outcomes here, again, Q4 2023 data, we saw an average time for an authorization to reach approval or denial around 26 hours. And when you compare kind of industry averages, and we reference, various sources to kind of see what was published in the industry from a timeliness standpoint, you'll see statistics that range from days to weeks. I think we've all seen examples where, it's a very specific clinical scenario, and it actually ends up taking quite a bit of time for that evaluation to occur. I'm super excited to see a 26-hour average turnaround time for that terminal decision from Humana in 26 hours. So really pleased on that. Also, when you kind of think forward to the landscape changing in the authorization space, as many of you know, we have upcoming regulation finalized by CMS to start in 2027. The timeliness components start in 2026. The 26-hour turnaround time really far exceeds even those targets set by that regulation, which differentiate between the urgent and kind of the standard order processing. So super excited with the resolution timeliness from the integration. We go to the next slide. And just to step back a little bit and think about kind of holistically the value and the benefits across kind of the healthcare spectrum and all the different entities involved. I mentioned earlier, of course, you have the patient. At the end of the day, this is really about how can we make sure that the patient is receiving appropriate, high quality care. And having an integration like the one that we developed takes the human out of the process. It creates a lot more standardization and consistency, ultimately, hopefully improving the accuracy of those outcomes on behalf of the patient. Additionally, we talked about the timeliness, so really accelerating the time for the practice to receive those authorization outcomes, which ultimately results in patients accelerating towards the care that their provider is choosing, to have that patient proceed with, which we've all been patients, and many of us have probably experienced frustrating auth situation, so we can empathize with the patient experience and the impact the integration has there. Then we move on to the provider. I think one of the great aspects of this feature, as Amy mentioned, is the direct integration within the provider workflow. So we saw the little kind of, widget boxes with those outcomes. Those are directly within the ordering workflow, very much integrated within the clinical experience within Athena Health. So that really meets the providers where they are. It reduces any kind of, launching new windows, going to other kind of websites or applications. It's bringing the information to where the clinical staff is working and making it more easily flow kind of downstream into other patient access activities. Then we have the EHR. So we have a common auth reference number that we deployed as part of this process, which really does ensure traceability end-to-end throughout the workflow. So we're able to kind of, go all the way upstream to the order, understand kind of the outcome of that specific order scenario, and then you can really trace it along the patient journey, which really helps to kind of keep track of things and make sure that the right information is present downstream, in particular, if any issues were to occur in any of the revenue cycle components of the claim. And then lastly, we have the payer, which, as we mentioned, the upfront collection of clinical details really does enhance the efficiency of the determination process. It really unblocks the payer to work optimally and provide an accurate determination the first time and avoid the back and forth that really ends up with a bad experience, both for the payer as well as the provider, practice staff, and ultimately the patient. So that's it for outcomes, value, and benefits. And I'm going to hand it over to Mark, who will talk a little bit about our lessons learned.
Yep. Thank you very much. Yeah, I mean, I think this is a great opportunity to look back. We've now been GA for getting close to a year, and the project's been ongoing for getting close to 3 years now. And where Da Vinci and the burden reduction documentation is today is very different than where it was back then. That being said, there's really an opportunity to learn some lessons from the project and the work that we've done. It really starts with good communications and working together between providers and payers and vendors to understand not only the Da Vinci implementation guides, looking back through understanding the components there, but understanding the individual workflows between the system and providers. Whether it's a provider or payer and they get the guide and they start looking through and saying, hey, here are the required fields I'm going to need, here's what's recommended. But then when you come together, you really do need to understand kind of that end-to-end workflow and how the data is shared between payers and providers. It really does help to identify and agree on service levels and key metrics to really guide you on where you want to go and what you're trying to improve upon. We talked already about some of the key metrics that we were focused on, reducing the number of touches and making sure we actually implemented the CRD component of that is out required early in the process, because we thought that would be offer a lot of value with less work, and we could get that value out earlier in the project. Another thing we worked on is creating that unique identifier through all the steps of the authorizations. As payers and providers are sitting together and understanding that end-to-end workflow, tracking that transaction as it goes between the different statuses of that CRD, the DTR, and the PS is important to make sure it ties down to that order and also to that claim. And that was a nice learning and some additional development that was important. And then finally, we're going to talk a little bit more about some of the data considerations. One of the key things that we were responsible for was taking the PAS FHIR bundle and converting that to the 278. And although that is no longer required as part of the CMS mandate, really understanding the data needs for both the payer and the provider side are important, even if it's just sending that same transaction. And I think that's what the end result of the data considerations really showed. So next slide. So one of the examples that we looked at talking about data was the service type code. So the service type code is standard in the X12-278 transaction. And on the payer side, it's a really important field that drives a lot of the functionality. When providers access a portal today, they're used to selecting that service type code, and they kind of just learn the appropriate service type code to enter. Payers that do use the service type code differently, and there's not a one-to-one mapping between like a CPT code and a service type code. So over time, providers learn how to submit an auth via the portal, or and now converting that into this type of bi-directional integration is challenging. That specific field is, although being required for the payer for a lot of their individual workflows, is not standard in EHR. So even if we were doing a FHIR type bundle, the payer still may be interested in wanting to receive that optional service type code because it's driving a lot of the functionality in their tool. So we did spend a lot of time kind of talking about this specific field and others similar like this, that like where one group requires the field or how this field is actually being used, and deciding how we're going to get that from the EHR to the payer and then back. We're really focused on that mapping of those FHIR resources to the X12 and making sure that the item is at the line item and not the patient level item. And is it required or not required as part of that deep conversation, just to make sure that the workflow works for both the payers and the providers. So these are this type of first off, both understanding the workflow pieces and then actually getting down to the individual data fields that are necessary for the authorization to flow seamlessly between payers and providers. That is a lot of the work that occurred during the development of this integration. Yeah. And the end result is that based on the work that we did, we actually gave feedback to the Da Vinci project. So these are the type of when groups get together and get down more than just a hackathon, but actually start to build something in production and get down to not just the easy use case, but all the challenging use cases end to end of like, hey, how do we feed that information back into the Da Vinci project? How do we think about these things more holistically across all the different use cases? And then updating those implementation guides and continuing that process. Actually, that's one of the things that we have on our upcoming list is to update to the latest versions of those APIs and making sure that we're staying up to date with those API guides as they continue to evolve over time based on lesson learned, not only from us, but from other groups. So it is really working collaboratively on a solution and then continuing to feed that back to this larger group, take other individuals learning and backing from those implementation guides, and then improve our individual process as well. So with that, I think we'll open it up to questions.
Excellent. Thank you so very much. Very informative presentation. Sorry, I didn't mean to turn my video on and then off. Meant to leave it on. All right, so we do have some questions from the audience. So I'm going to go ahead and run those as they've come in. So there was a question about the typical categories that require prior auth. Anyone in particular want to answer that question?
Amy, you can chime in, but my understanding is it really is very widely by the payer. It's really a payer, individual sort of determination to decide based on that specific health plan that they're offering with that specific, provider, what will be in and what will be out, which is, I think, what contributes to the complexity of the overall process, right? Is that there's not often trends that you can rely on so consistently, which really creates a lot of the burden that practices experience because they need to sort of double check, each one. Because you don't want to be wrong, because that really creates a bad patient experience.
Yeah, I would agree fully, Jillian. It really does depend, and also it's line of business and payer, and even down to the individual group plans. So you definitely will see a lot more prior auth for things such as like procedures, like actual procedures versus the consults in a lot of cases. But again, it is not at a category level. It's really driven at a CPT code level.
And so was there a lot of complexities in your ability to get the prior authorization related rules with that combination of the human with the plan and all those details? Can you speak to any of the effort to get that ready so that this whole life cycle that you're describing could actually flow?
Yeah, so absolutely. From a payer standpoint, we had been working on something similar for a while, trying to figure out how to determine an is auth required check for providers. However, I think let me back up. So we definitely spent a lot of time on that prior to this project itself. So outside of just this workflow, we were working on it. We definitely have to digitize, find ways to digitize our prior authorization lists that are established out there and develop a lot of logic based on, just as Jillian mentioned, it might be the member plan, it might be the provider that's submitting. They may have unique rules. It may be that employer group that member's a part of or other grouping. But then lastly, we still have some scenarios where in the authorization, the kickoff of the CRD component, we don't have enough information at that time to determine whether or not an auth is required. So there are additional considerations. So for instance, if you do it at a time of ordering, you may not know the facility or the actual treating provider, and that might also impact whether or not an authorization is required based on where you're going. So in some cases, we are still seeing, in an example of something we're working through and trying to work, is we may say, yes, an authorization is required. We're going to take that safer route. But then on submission, we're like, oh, with further information, it's no longer required. So it's definitely complicated, and I expect to be a continually evolving process.
Thank you, Amy. There was another question sort of related to the prior authorization approval rate. Does the 70% auto approval rate include the cases where prior auth was not required?
So that doesn't include the cases where prior auth was not required. So those are exclusively for those flowing through the integration. 70% received the auto approval. So that's kind of, you know, the 54% is the volume that doesn't require an authorization. So that's already kind of carved off to the side. So that which remains, 70% of that volume received an auto approval.
That's very impressive. That also does, as you noted earlier, speed the ability for that clinician and the patient to get that care delivery actually fulfilled. I'd like to ask another question around that was submitted. Can you talk about the technical details of the implementation? Like, where are the gaps in the implementation guides, and what are some key takeaways on the technical side?
Yeah, I can talk a little bit about the transition between the Fire bundle and the 278. I'm going to start at a higher level, is that there are definitely pieces of the implementation guide that are great goals to move towards, but may not be necessary to meet the guide. In this specific example, let me give an example. In this specific case, we did not use Fire to extract clinical data to automatically answer the medical necessity questions as part of the DTR. You know, this workflow was to launch give a URL and have that launch and have an end user answer those clinical questions. So there's definitely opportunities to move forward to improve our overall integration and improve our overall automation. And although that information is all in the Da Vinci implementation guides, we're realizing, like, definitely doing that crawl, walk, run. Let's get the data flowing back and forth, and then looking at ways to expand that process. Specifically with converting from a Fire PAS bundle into a 278 is really taking that mapping information between the Fire bundle, looking at the 278, going almost field by field and saying, okay, where does this fit in both that request going from the provider as well as a response coming back from the payer, and then doing that individual work in standardization and mapping process.
I think it's really interesting that the layers that we have to bring together. There's sort of the capabilities to exchange the data, there's the data structures, and then there's the value sets, and then there's the terminologies that then all have to be understood on either end of the pipe so that the workflows can really function. And we have a lot of legacy terminologies and value sets, and just because the extraction and exchange capabilities may be changing doesn't mean the terminologies and the value sets that we're so accustomed to using will change. And that brings some interesting operational consideration. And I appreciate your perspective of, you know, incrementally working this out, because it's kind of like another analogy is like in Shrek, when we pull back the layers of the onion and find a look at all the pieces of the puzzle. And what we want to do is make sure that we get to the goodness of the patient care at the center of it. But all those layers to automate this is pretty complex. And what we have to learn, we're going to get to the point where we're going to do more exception handling, where the data extraction cannot be interpreted reliably enough to give us that end answer. And so I'm curious about sort of that end user experience when you do have additional data that's needed. You know, I think you currently said that you're sending a URL, and then they can open that, and then there's I think I saw the word PDF being sent back now for the completing of that. Do you want to unpack that a little bit more to make sure that we're all understanding how that additional data process is really working at this stage and where you see it evolving into?
Yep. I think, oh, go ahead.
I was just going to jump in, Mark, just to talk about it from the sort of practice experience standpoint. So the URL that gets passed back ultimately surfaces in a, you know, embedded questionnaire widget, if you will. And that allows, again, the user seamlessly within the workflow to key in the responses to those additional clinical questions that are required. That then sort of drops into the Fire bundle, you know, as a total package with, you mentioned the PDF. The clinical documentation that's sent additionally is an encoded PDF of the encounter summary for the visit to which that order is attached. And that would have all of the relevant clinical documentation from that specific clinical encounter that the patient had with the provider that presented the order that is flowing through the integration. Sorry, Mark, if you had anything to add.
Nope, I think that's it exactly, is that is, and I think the other piece is that important is that one of the questions that was asked about, hey, what if you chose to go fire? You know, why are you converting the 278? And is the 278 causing the issue? And I'll say maybe yes, maybe no. If the payer's tool requires fields like a service type, regardless of if you use a 278 or if you use a fire, if it is up to them to decide the fields are required to meet their needs. And so part of this work is also the opportunity for payers, and maybe Amy can talk more about that, about changes that they made in their workflow based on the data that was available in the EHR and the data that's flowing back and forth.
Yeah, absolutely. So I know I saw that question as well. So something, just as Mark mentioned, something is like the service type is absolutely key in our logic. So even though it's not part of a fire build, and I think that was another question, is what are the technical gaps? They're not necessarily technical, but in a lot of cases, there's data gaps. So elements that are needed for decisioning that we may not be getting today in the current use. So we had to kind of make it our own, which is really where the collaboration came from. So for instance, with the service type, there was an instance where there was a certain service type that was very rarely used, that had very minimal impact. So we just agreed, like, let's kind of bypass that one and focus on the largest opportunity, because it was hard to map in that service type to meet the needs for all patients, because it was very rarely used. So I think in another gap that I would call out is provider data as an example. So within this workflow, there's really no standardization of provider data across all payers and all providers. So some payers may contract at the 10 levels, where others are at the MPI or individual, either group MPI or individual MPI. And so you do have instances where, I think Athena had some areas where they didn't have facility PIN information or MPI information, in which we needed that information to process. So there were some steps that had to be taken on the Athena side to load that provider data in order for it to be sent within the transaction automatically. So I think every day, we uncover new opportunities where data is missing on one side or the other, and we say, okay, how do we work through that together? Because previously it was someone going into, in a lot of cases, a portal and manually entering or searching or being able to enter that. Now we're having to pull it with zero manual intervention, and we're going to inherently fall into issues when it comes to automating such a manual process.
So how have you kind of collaborated around that? Because you've got sort of the internal policy from the payer perspective on the prior authorization rules. You've got the potentially G10 EHR certified sort of capabilities coming, on the provider side, and then you've got the clearinghouse support in the middle in this example. How are you collaborating on that? Because it sounds like every potential exchange could bring you a new treasure trove of opportunities.
Yeah, I think
lots of meetings.
Yeah, I mean, you kind of alluded to it there too. Like,
Did Julian freeze for anybody else?
Yes, I think she did.
Oh no!
So, I think, and I not to speak for Julian, because I don't know where she was going.
She just came back. Julian,
did I freeze?
You did. Can
Am
you
I
say
back?
You're back.
Okay, good. What a time to have internet issues. But just to repeat what I said, so I think Alex, you were kind of alluding to it in your comment, but reporting and analysis, I think, is really essential. So having infrastructure set up so that you can evaluate each of those kind of points in the process to be able to learn about where you're succeeding, where you're failing, what your issues are, as well as Amy talked about kind of the release progress that we made, starting small, launch with your alpha, get some things flowing, see what kind of outcomes you're getting, and that will point you in the direction of where your opportunities lie and where you need to kind of invest more. And then, as Amy said, it really it's a lot of time. And ultimately, it was 3 organizations coming together as a working team, really functioning as one team, which was kind of a rare and exciting experience for me professionally, to be that embedded, outside of my own company with other people, sort of mutually responsible and sort of equally needed to be able to be successful in the overall integration. So, and we of course continue to engage and evaluate the outcomes, post GA and figure out what those opportunities are to improve.
Okay, so I see you're answering some of the questions, so I'm not sure if you're responding to everybody or just to the person that asked the question. So I do want to I apologize. I'm going to backtrack a little bit just to make sure that we don't cut out everybody from the learning experience. I think you've just clarified that it was internal policy only, that you weren't
Correct.
using another organization's guidelines for processing the prior authorization rules. So that was great. I have a question around what are some new use cases you're looking at for prior authorization? For example, in some cases, attachments might be sent late. How do you match those attachments that come in asynchronous? What are the other examples of payer use cases where the basic data integration isn't enough? That's a lot of questions.
Yeah, so yeah, no, that's a really great question though, because these are the sort of questions, I will say I'm very excited about this work and I see a lot of opportunities. As Mark mentioned, it was getting the pipes built and now what's next. So in this use case specifically, the attachment data is coming in with the authorization. So we're not getting it late in the initial submission. Now, there is absolutely the opportunity, however, if we need more information. So if what was sent is not enough for us to decision, in current process, what's happening is our operation teams are reverting back to what happened previously, which is picking up the phone and calling or sending a fax, whatever their pre-established process was, if we're not getting the data that's needed. We're seeing fewer and fewer instances of that because we are getting the data up front. But for me, an opportunity to expand this would be post-submission. And as we're already directly connected with the CDS hook, so is there a way to real-time connect back and request more specific clinical data? Maybe we're missing a specific lab we were looking for that we didn't see within the document that was sent. So I do definitely see more bi-directional communication as a use case in the future. It's more figuring out where the biggest opportunity is. We also do see opportunities for things like providing even, I don't want to say steerage because that is not the proper word, but education. So maybe the code that you're submitting most likely won't be approved. Like maybe it's something that's like a most likely or is not on like it's a really high cost. And we say, based on our historical data on this member, we're not seeing that they would meet the policy. So, hey, have you tried this instead? Or this would be more likely to get a quicker approval. Now that does require significant operational review and search into like those use cases one-off, but I do believe that now we have established that bi-directional connection, we will be able to go back and forth. I think the other, I think of with the price transparency, the work that continues ongoing is bringing up the transparency of the costs associated with services. That's also an opportunity to build that into this. So I think that this is just the beginning. We definitely want to continue to expand. I did respond to one that was already answered, but primarily this is built out for outpatients because Athena is outpatient service. That is the primary, or they primarily support outpatient services. And the Da Vinci specs are really written more from an outpatient perspective, but there's also the inpatient use cases where you're really always, most of the time going to require that off, but getting that information automated is still critical. And they will have different med policies that need to get built out for that, such as MCG. So those are just a few. I could go on all day about opportunities that I see where this could work.
Jillian or Mark, do you want to weigh in on any of those other opportunities that you see on the horizon?
I just double down on the clinical documentation and the attachments. I think in today's manual process, that's often where conversations go in managing the complexity and the completeness of the submission. So I think Amy makes some great points on how can we create bi-directional connectivity to sort of enhance the flow and the engagement between the provider and the payer and really like connect those parties. I think that'll be an interesting area for all of us to explore as we move forward.
Yeah, especially as we're starting to leverage the PDex, the clinical data exchange capabilities, as a part of a supplemental activity for the burden reduction, 3 implementation guides of CRD, DTR, and PAS that you've been talking about today. And I think that this is also beholden to our opportunities to get data out of the EHR and then have a diversity of capabilities as a part of a payload that can exchange that information, so we can really meet people where they're at. And that power of the electronic health record being the repository for the critical information that's needed for those other processes. It's important to get the data into the right fields so that it can be acquired, compiled, and transmitted. And I think that the suite of implementation guides with clinical data exchange, Swiss Army knife, as I like to refer to it, really will enable us to sort of ensure that we can meet the end users' technology capabilities where they're at and provide the diversity of functions. But there is a question related to this FHIR questionnaire. And there was can the FHIR questionnaire and the widget be put in a work queue to be completed later, possibly by a practice staff?
It can, and that's actually more or less kind of the model that exists within Athena today. So, that URL comes back from Humana, and then on the EHR side, you need to create or have an existing structure in which you would basically plug that URL into. So in Athena, we talk a lot about kind of work management and how do you distribute actionable tasks to practice staff. And essentially, we kind of plug into some of the processes that exist around our work management capabilities. So there's already a structure for that, and then you sort of receive in the URL. And then from that URL, you embed it in the work management capabilities, and from that launches the questionnaire, which could be, queued up in a work queue for a certain, set of individuals that work on authorization needs.
Really sounds like there's a very much of a focus about meeting the provider workflows and automating as much as possible. And I think it's great to see that we can actually parse out the work across the staff team to really make sure that we can move the patient care forward as quickly and as efficiently as possible, so we can use people to their highest, best capabilities, which is part of what we're trying to do with the value-based care standards that the implementation guides have manifested from the Da Vinci project, as well as other accelerators, to try to reduce the burden, increase the automation, because we already have fingertips on keyboards capturing that data or translating it through natural language processing into discrete data. And that high fidelity discrete data is ultimately, through the systems and automating its exchange capabilities with the multitude of security and privacy functions that wrapped around it, is really going to help extend that or take us to that next level of burden reduction, and so that the patients can really get the most time with their providers and maximizing their care. So I want to see if there's any other final questions from the audience before we wrap up today. Please go ahead and submit those. And I would also, as we've been talking here, Amy, Mark, and Jillian, any final thoughts or comments through your experience and your collaboration? It seems like it's been a really productive one. I can feel the passion from all of you on supporting your members and your patients, depending on how much side of the house you come from. But any final parting words today?
I'll just say, first off, thank you very much. I think this type of conversation is really important, that the lessons learned and realizing you must be flexible in these types of implementations, and will likely have to change your workflow both on the provider side and the payer side, is really important. And I think giving back and having these types of conversations is important. So let's continue the conversation, continue reaching out, and let's continue to move this automation forward.
And it's a really good point that this takes a village to address our needs, and we learn every step of the way. It's a life cycle. It's a never-ending learning health system, and we need all voices at the table. So I would encourage folks to think about, as they're implementing the rules, or they're implementing the implementation guides to advance their business strategies, think about coming back into the community, exercising your voice, helping us improve the implementation guides, because it's going to take us a while to unpack all the opportunities to really get to the utmost burden reduction that we can and the supportive patient outcomes. So in the deck that will be posted tomorrow along with the recording, you will see some background information in the appendix that helps you understand where Da Vinci work use case calls are happening and when, and they're open to everyone. I hope you all realize that the Confluence resources and the implementation guides are all freely available to anybody who wants to pick them up. Even my mom, if she wanted to in the nursing home, could go log on and look at these IGs. So please come into the Da Vinci community and help us make our implementation guides better so that it will benefit all of us and those we love. And with that, I'm going to applaud our fantastic presenters today, our 2023 class of champions, and invite you all to join us June 26th for our next community roundtable. And in the interim, I hope you all have a great balance of your day. Thank you. Take care.